Today I'm with Dr. Rajamanuri. She's a third-year internal medicine resident at SIU School of Medicine. July, she will be starting her GI fellowship at Medical College of Georgia, and in this video we'll be discussing GI bleeds. So the first question I have is, what are the key clinical signs that help you distinguish between upper and lower GI bleeds?
Okay, so to start with, upper GI bleed is any bleed that's coming from proximal to the distal ligament of Treitz, and lower GI bleed is distal to the ligament of Treitz, right? So most common presentation for an upper GI bleed is hematemesis, that is bloody vomitus, and melena. These are the two most common presentations. Melena is just black tarry stool that's been sitting in your GI tract for a long time, and then you get that out as black stool. And lower GI bleed is most commonly hematochezia, which is bright red blood per rectum. Having said that, sometimes upper GI bleed can also present as hematochezia if it's massive GI bleed. So these are most common presentations, but you can always have exceptions to that.
What are some of the can't-miss symptoms that suggest a life-threatening GI bleed?
Definitely hypotension. That's the biggest clinical presentation of a massive GI bleed: hypotension, tachycardia, causing hypovolemia, right? So with hypotension, you need to keep in mind that some patients can have relative hypotension. Some patients may have a baseline blood pressure of 160s, 170s. If they come in with a 120, that is not normal for them. It's still low, so you need to take that into account. The other signs would be, blood loss, anemia, and if they have symptoms like low like energy levels, or if they're feeling cold, clammy, and for you to assess if they're having low urine output, these are all signs that there's some kind of blood loss or volume loss that's going on. And in addition, if you see that their hemoglobin is dropping, that's probably suggestive of a GI bleed.
Perfect. Now, moving on to the management, what are some of the essential steps in stabilizing a patient with a suspected GI bleed before a definitive diagnosis?
Well, for any patient that is unstable, you want to make sure your ABCs are checked. So airway, breathing, circulation, 2 large bore IVs, and fluid resuscitation as needed to keep their blood pressure up, and blood products. So it depends on what the cause of GI bleed is. If it's variceal bleed, you don't want to increase their hemoglobin beyond 8, because increasing intravascular volume can predispose them to have more bleeding from the varix itself. But otherwise, if they're actively bleeding, then some patients can get blood products even if their hemoglobin is 8.
When should endoscopy be performed, and how do you decide between urgent and elective timing?
Yeah, that's a good question. Again, that depends on the cause of your GI bleed, upper GI bleed. So if they are hemodynamically unstable, your goal is to first stabilize them, make sure their vitals are stable with fluid resuscitation, blood products as needed. And if they are bleeding because of varices, then it is 12 hours. The window for endoscopy is considered 12 hours, and if it's non-variceal, it's 24 hours. So depending on when they come in, you'll have to get GI on board.
How should students and interns approach suspected variceal bleeding in cirrhotic patients?
Well, you still need to do all the essential steps of ABCs, and then for variceal bleed specifically, you need to make sure they are on SBP prophylaxis. They need to be on ceftriaxone, and they also need to be on octreotide. That is to kind of, it's a splanchnic vasodilator, so you need to start them on octreotide and fluid resuscitate them, put them on SBP prophylaxis, call GI immediately. Scope needs to be done within 12 hours.
Perfect. What is the role of interventional radiology in patients with persistent or recurrent GI bleeds?
So there are a few indications for interventional radiology to come in for recurrent or persistent GI bleeds. If there's an active lower GI bleed like hematochezia and the patient is getting unstable, then it would be prudent to get a CPA and go in for an IR guided embolization. Because even if you go in with a scope, you won't have a clear view because of the blood that's coming out if it's an active bleed. And the other indication would be if they have a gastric varix that's bleeding, then you can do something called a BRTO. BRTO is balloon occluded retrograde transvenous obliteration. That's done by IR. In more severe cases or more extreme cases, they would do a TIPS procedure. And TIPS is transjugular intrahepatic photosystemic shunt. TIPS. So that is another option for gastric variceal bleed, or even for recurrent varices. That's another option. So if somebody's having esophageal variceal bleed and they're having multiple episodes of it, TIPS is an option for them.
After stabilization and treatment, what are the critical follow-up steps to prevent recurrence of GI bleeds?
I would again say that this depends on the cause of the GI bleed. If we are talking about, say, a lower GI bleed from diverticulosis or something like that, diverticulitis or diverticular bleed basically, then you want to prevent them from having constipation or anything that may provoke this to happen again. And if these are ulcer bleeds, like gastric ulcer, peptic ulcer bleeds, then you want them to continue PPI therapy, right? In order to prevent this from happening again, and make sure the risk factor that's in place if they're having peptic ulcers from NSAIDs need to be stopped. And if they have H. pylori, that needs to be treated. If they are having variceal bleed, then prophylactically, for secondary prophylaxis, they would be needing frequent EGDs. If they've had variceal bleed, they'll need frequent EGDs to keep monitoring to make sure they're not developing new varices. And if they are developing new varices and they're having recurrent GI bleeds or variceal bleeds, then they will need a TIPS procedure.
Perfect. Yeah, thank you so much.